Hello, I'm Terry Olguin with the Learning and Professional Development Team, and welcome to this training session on the start of care process. This session is designed for field staff who perform the clinical comprehensive assessments. Let's get started by reviewing our objectives. By the end of today's session, the RN, social worker, and spiritual care team members will be able to follow process steps for opening, documenting, closing, and sending the first required assessment. You will also be able to explain a level of care changes and information flow. Our focus today will be system functionality and how the information flows between the various forms in the system. Occasionally, we'll reference forms that may look different than the system screen. However, the content and process flows are the same as you know it today. You will have the opportunity to take additional instructional sessions to learn more about additional forms used during the charting process, such as the comprehensive drug profile and routine visit class. Let's look at the steps taken to open, document, close, and transmit the documents necessary for the start of care. A patient has been assigned to you for admission assessment. Start by selecting your patient. Next, do your research. This means reviewing patient information prior to your assessment. Nurses will begin selecting an admission packet. Social workers and spiritual care coordinators will select their appropriate assessments from the visit documentation area of the system. The next step is assessing your patients, as you would typically do, followed by documenting your assessment findings. When you are done with your assessment of the patient, the form is electronically signed and sent to office. Let's walk through these steps in more detail. We'll start with selecting a patient. This is the main menu where each discipline has the drop-down in the upper left corner of their screen to click on and select the patient. Start by clicking on My Patients drop-down and selecting the patient. Patients are assigned initially by the admission coordinator or the office staff. If you don't see the patient that you are searching for, contact the office and ask them to assign the patient to you. As you can see, this is the only patient assigned to me. The next step is to review the patient's referral records. This means reviewing patient information prior to the assessment of the patient. This review helps you prepare for the assessment. This information can be found on the patient's face sheet or in the patient's chart. You will want to review the patient's consent information, the H&P, and other documents that should be loaded to the patient's chart. In the system, the face sheet is called the patient profile. Click on the patient profile link next to the patient drop-down to see the patient's face sheet. Information such as a patient demographics, physicians, referral information, insurance, and much more is found on the face sheet. You will want to look closely at the referral notes, as this is where you will find information on the benefit period and prior hospice data needed for the nursing assessment. To look at uploaded consents if the consents are performed by someone other than the admission nurse. Uploaded documents may include other patient information such as history and physical and lab work that the admission coordinator may have gathered in the referral process. Click on the patient chart link, which is besides the patient profile link. You will also be able to get to the patient profile or face sheet while you are in the patient chart and get to the patient chart while you are in the face sheet. This quick tip saves you from coming back to the main menu each time. After the patient has been selected and the face sheet has been reviewed, we are ready to begin with our assessment steps. Let's review those for each discipline. The RN will work with and select the admission packet from My Forms menu. Notice there are several types of packets: an admission assessment packet, a research packet for 60 and 90 days, and a discharge packet. Since we are doing an admission visit, we would select the admission assessment packet to find the necessary forms. To understand how packets work, think of packets as file folders which contain all of the forms needed for that process. Packets help organize your screen. For example, the admission assessment packet has many forms, not all of them required. Instead of picking and choosing from many forms from different areas, they are all contained within this file for you. Now we're in the admission packet, and you can see a list of all of the forms in the packet. The starred forms are required forms for all patients. They include the Nursing Comprehensive Admission Assessment or Nursing Initial Admission Assessment, Comprehensive Assessment Drug Profile, Clinical Review for Support of Hospice Eligibility, Attending Physician Certification of Terminal Illness, Hospice Physician Certification of Terminal Illness, Informed Consent, Election of Benefits, Interdisciplinary Plan of Care, and lastly, Patient Emergency Information. The forms that are not starred may or may not be used depending on your patient needs. The payer screening questionnaire should be completed with the additional start of care forms completed during the consent process. Let's review the Nursing Comprehensive Admission Assessment and look at the functionality of the system for this form. When selecting the first assessment, it must be based on the current needs of the patient. Use of the initial admission assessment should be an exception or rare. Remember, it is used when the patient or family is unable to tolerate the completion of the full Nursing Comprehensive Admission Assessment. An important difference in the system is that the initial admission assessment, when sent to the office, does not change the status of the patient to admitted, where the comprehensive form does. If the patient is able to tolerate the full assessment, we will choose the Nursing Comprehensive Admission Assessment and begin our documentation. Remember, selection of the type of first assessment is based on the patient need and not of the clinician. The social worker and spiritual care will select their assessment forms from their respective main menu. Here we see the main menus for the social worker and spiritual care, with both the social work assessment and the spiritual care assessment highlighted. The next step for each discipline is assessing and documenting your findings as you would normally do. In the beginning, while you're getting used to the system, it may be difficult to do all of your charting while you are with the patient. The goal, however, is to get to that point. Make sure that you are engaging with the patient and family and not spending too much time staring at your device. Obviously, this gets easier with practice and over time. You should have heard about employee time slip in the overview class. Everyone will be doing a time slip the same way. Remember, the employee time slip is added to each form that is associated with an assessment or visit. The time slip area is the same on every form that is designated as a visit form regardless of discipline. The time slip captures visit time, which has to go on our claim for several disciplines, time travel, charting time, and supervisory information is entered when applicable. At the end of the visit, you will need to have the patient or caregiver sign the assessment. This is consistent with our policy and provides proof that the visit was made. Throughout the comprehensive admission assessment, the admitting nurse will capture information to flow to the HIS form. HIS questions are easily identified on the Nursing Comprehensive Admission Assessments. If you are missing any of the HIS questions on the assessment, you will receive the assessment back to be corrected. Remember to check your To Be Corrected folder frequently, as the HIS information is time sensitive. For more detailed instruction on the HIS indicators or responses, please see your Manager of Clinical Practice. Let's look at an important new addition to the comprehensive admission assessment, the hospice benefit period information. The hospice benefit period information is not on the paper form, but it is on the system form. This information is critical to how the information flows to additional admission forms, so we want to provide a few tips on how to gather and accomplish this task. The admission coordinator will check financial eligibility, looking for the Medicare hospice benefit and any other payers as they do now to determine primary and secondary payers for hospice care. They will then send their findings to the admitting RN by using the referral information or RI note. As mentioned a short time ago, this will be found on the face sheet or patient profile under the Referral Commons area, so it is important to do your review of the face sheet. As mentioned, the admitting RN will add this information to the Nursing Comprehensive Admission Assessment. Completing and sending your assessment to the office admits the patient in both systems, so getting your assessment done and sent to the office timely is critical. Let's look at this section one step at a time. We will start with the hospice SOC reason shown in the drop-down below in the blue window. If the patient has never received hospice before, he or she would be in the first benefit period. In the hospice SOC reason, you would leave the default to select one. In other words, ignore any of the choices as they would be incorrect. If the patient is transferring to our service from another hospice and there has been no break in service, we would choose transfer from another hospice agency. If the patient had revoked hospice in the first 90-day benefit period, we would choose this option and the patient would be in benefit period 2. If the patient had revoked in the second 90-day benefit period or any of the 60-day benefit periods, we would choose this and the patient would be going into benefit period 3, 4, 5, etc. The SOC date is the date of admission or date of transfer to your program. If the patient is electing the Medicare hospice benefit for the first time, enter the date of election. If the patient has revoked or discharged, leave the start of hospice care blank. If the patient transferred to your program, enter the election of benefit date of the transferring hospice provider with the different provider number. The prior hospice information is left blank if the patient is electing the Medicare hospice benefit for the first time. If the patient had prior hospice information, enter the election date as the first ever election of benefit date. If the patient is transferring, enter the transfer date or the current election of benefit date. In the prior days of hospice, enter the number of days used with the transferring hospice with that different provider number or the most recent hospice election with different provider number. Again, entering the prior hospice information will allow the system to calculate the needed benefit period number and the number of remaining days in the event of a transfer. We can also see the benefit period number and benefit period dates flow from the assessment to the IDG POC. Next, to enter a diagnosis, enter the diagnosis description in the proposed principal diagnosis area. Enter the date of diagnosis. It is important to enter the correct principal or terminal diagnosis as certified by the attending and hospice physician. The principal diagnosis flows to the hospice initial order form. The diagnosis list will flow from your assessment to the IDG POC, and the system will allow you to edit the diagnosis list on the IDG POC at the IDG meeting. The hospice physician reviews the diagnosis at the time of the first meeting after the patient is admitted and determines relatedness at that time. This process hasn't changed. Where the diagnoses are documented has changed. For the additional diagnosis, free text into the brief medical history field additional diagnosis. As you can tell, there's some new functionality on the assessment form. Besides auto sum to total things such as FAST scores, drop-down ratings for different systems were also added. You will also have the ability to drag and drop markers to show pain and wound locations. On the nursing assessment, you have the ability to describe 4 different pain sites. It is important that you rate as much as you can, even character, duration, frequency for nonverbal patients, if possible. Note, the primary location A is in purple font. Entering patient information is part of an HIS question, so CMS is asking us for the patient's pain location, severity, character, duration, and frequency. The next area of review is the plan of care problems, goals, and intervention, as it provides additional information to different areas of the system. The page begins with the entry of the admission level of care. The patient level of care is established on the Nursing Comprehensive Admission Assessment. It is important to select the level of care. This will begin to flow to the level of care throughout the subsequent documents, such as the Interdisciplinary Plan of Care Review and Update Form. In addition, the level of care designated also flows back to McKesson Hospice as the event used for the billing process. The word None will first appear next to the level of care label. It is the link that the nurse will click on to establish the level of care. Upon selecting the link, a pop-up box will appear labeled Levels of Care. The nurse selects the Level of Care drop-down menu, which displays the available levels of care for routine, continuous, respite, and inpatient. The nurse selects the appropriate level of care for the patient. Enter the start date and start time for the level of care and click the Save button within the pop-up box. After clicking Save, the level of care pop-up box will disappear and will no longer reflect the word None as the link. Instead, the designated level of care will appear along with the start date for that level of care. In this example, you see the routine level of care that was established on the start of care date. Next, we will review the location of care for the patient. Home will appear if the patient is residing in a private residence. If the patient is residing or temporarily in a facility of any type, it will be displayed, including the address information for the facility. Should any location of care be incorrect, submit a change in patient information form to the office for update to McKesson Hospice. The admitting RN will document the verbal order information when they discuss their assessment of the patient with the hospice physician. The system auto-creates the form shown on the left, known as the Hospice Physician Initial Order Form with this information. This order form is sent to the Hospice Medical Director for signature. As you remember from our overview class, when the assessment is completed, return back to page 1 and enter your visit timeout. Next, click on the patient signature box and a large signature box will appear on the screen to allow the patient or family member to sign in. Let's review the next step to turn in your electronic document. When you are done with your assessment of the patient, you electronically sign the form and send it to office. Once you have entered your visit end time and captured the patient's signature, your next step will be to click on the Send to Office button. This means you consider the form finished and it goes to your completed form section. If you are done with the form but not yet ready to send it, you would click on the Sign Save. Be sure when the dialog box asks if you want to complete with or without a signature to choose with a signature option. The timing in which you get these forms completed and sent to the office is critical. Until these are sent to office, the patient is not admitted and the form cannot be created or submitted to CMS as required. Other forms as well cannot be auto-populated or created. Sending this form to the office starts the flow of information between both systems and also hospice scripts. Timeliness is critical. When you sign and send the comprehensive admission assessment, the patient changes to admitted status. Once a med profile is filled out, it also flows to hospice scripts when the initial or comprehensive is sent. Again, timeliness of signing and sending these forms is important. The comprehensive drug profile will be discussed in much more detail in the comprehensive drug profile class. Now let's look at the forms used during the recertification process at the time of admission. We'll be reviewing the clinical review of support of hospice eligibility, the attending physician, and the hospice physician certification of terminal illness form. First, let's talk about changes around the certification process. As you do now, the RN completes a clinical review for support of hospice eligibility. Disease-specific guidelines will need to be completed on this form. Remember that while you focus on principal diagnosis section of this form, it is important to document anything that will help demonstrate clinical decline. Findings should be discussed with the hospice physician at the IDG meeting. This form gives the physician disease-specific information and will help paint the picture of clinical decline as a patient is certified for hospice. When you are finished with this form, send it to the office. The hospice physician will be able to find this completed form in the patient chart. The RN has the hospice physician certification and recertification in the admission assessment packet. Open the certification form, enter the date the verbal order was received, the physician's name, your name, and the date, and save the form. Once you have saved the form, then the button for pushing will be available on the bottom of your form. Push the form to the hospice medical director for completion of the narrative area of the form. Note, do not send to office as it will lock the form for editing by the physician. Next, complete the attending physician certification once the admitting RN receives the verbal certification. Enter the verbal certification information by entering in the date the verbal order was received, the physician's name, your name, and date, and select Send to Office. Be sure to select with signature when prompted. The office administrative staff will send the completed document to the attending physician via fax or print for order processing. The attending physician needs to be involved with admitting orders. Any verbal order secured from the attending physician can be documented on the hospice admission orders form. This will ensure that the attending physician is aware and in agreement with hospice for his or her patient. As you know, the physician should be on board with hospice as a plan for his or her patient before being sent the attending physician certification of terminal illness form. Now let's look at the hospice aid form. The hospice aid assignment and hospice aid visit note are formatted so that we could maximize system functionality. Enter as appropriate the vital signs. If you do not want the hospice aid to take vitals, don't assign them. If applicable, the assignment can be performed as one-person assist or two-person assist. The assignment will auto-populate on the hospice aid visit note in the assigned column, and when the care is provided, the aid checks care performed. As you can see, the aid has the ability to document notes besides the different assigned tasks. The assignment is a shared form, so the RN makes the changes to the assignment. The changes flow to the hospice aid visit note. Also, they are both shared forms. It is easy for the aide to see the assignment. The patient emergency information form is completed for all patients. Next, the admitting nurse will document the scope and frequency for the social worker and the spiritual care coordinator as determined by the IDG on admission. The social worker and the spiritual care coordinator will complete their respective comprehensive assessments within that required time frame. We will learn momentarily how the plan of care is documented following the psychosocial assessments. Let's review the plan of care flow. The establishment of the plan of care, scope, and frequency are documented separately from the nursing admission assessment. The RN will use the IDG plan of care form to document this information. Although the IDG plan of care form is initiated by the admission nurse, it is a shared document and can be updated by any core IDG team member. Initially, the social worker and the spiritual care coordinator will document their plan of care findings on the IDG plan of care or the IDG plan of care review and update form, following completion of each of their respective comprehensive assessments. It is based on timing when the first IDG takes place and when the assessment is performed that determines which form is used. All subsequent IDG POC review and update forms will auto-populate information from one form to the next. This means you'll be able to see the patient's problems, goals, interventions, and changes in real time or as they are documented. That will help you give a more accurate picture of your patient. As you know, we are required to establish the plan of care prior to providing care. So let's look at the establishment of the plan of care, which is on the IDG plan of care form. Note that you are to document the name and the role of the family or caregiver you talked with about the patient's plan of care. If the patient resides in a facility, please document the name and title of the facility nurse that you discussed the patient's plan of care with. This is one way that we demonstrate coordination of care. The next portion of the IDG POC documentation contains scope and frequency for the IDG. The frequency cannot equal 0 for any discipline, and the system does not allow frequency ranges. We also know that it is challenging to predict visit frequency when hospice patients' conditions can change so rapidly. The admitting RN determines how many times the patient will be seen from this point forward. So let's say the RN will see the patient twice a week for the next 2 weeks. That would be written in text format as 2 times a week for 2 weeks. If a hospice aide is needed, the admitting RN makes the hospice aide assignment. Based on that assignment, let's say the hospice aide is to see that patient 3 times per week for the next 2 weeks. That would be written as 3 times a week times 2 weeks. If the physician is not scheduled to see the patient, leave that blank. For the social worker and spiritual care, this frequency is from now to the first IDG meeting. We know that those disciplines are required to assess the patient within 5 calendar days from election of the hospice benefit. So we would also write, as you do now, times 1 to assess. If the social work service has been refused, document the conversation in the narrative and leave the frequency blank. If a volunteer has been requested, you would also document times 1 to assess. The manager of volunteer services would determine those needs. If a volunteer has not been requested, leave the box blank. Use the checkbox to indicate the IDG approves of the unscheduled visits provided at the request of the patient, family, caregiver. And lastly, remember, these are planned frequencies. We will make as many visits as our patients need. These frequencies are reviewed at IDG meetings and determined for the time period between those meetings. We've covered a lot of information in this class. You should be able to follow process steps for opening, documenting, closing, and transmitting your comprehensive assessment and be able to explain how the plan of care has changed. The RN should be able to do the same for additional forms that are used during the admission process.
That concludes this training session. Thank you for your participation, and we hope you found this session informative and helpful as we collaborate together to deliver uncompromising care. Thank you.